So I want to talk about a case that I did about 3, 4 years ago. The case is a 30-year-old male who presented to my office with pretty significant left pain in his flank region extending into his anterior thigh. He underwent an MRI and it showed that there was a mass, and it looked to be what's called a nerve sheath tumor, but it was located outside the spine. Typically when we see a nerve sheath tumor like a schwannoma, it's usually within a portion of the spinal canal, extending in the spinal canal and outside the spinal canal. This was one that was found completely outside the spinal canal, embedded in a muscle that's called the psoas muscle. So I'm going to go through the films with you now. This is the sagittal MRI with contrast. This is L5, this is L4, this is L3. And when we scroll out laterally on this film, we can see that there is a mass at about the level of L3, just inferior to the L3 neuroforamen, which is right here. And as you can see, there's this large, hyper-intense structure that is lighting up with contrast. This appears to be embedded in this muscle here, which is called the psoas muscle. Now, when we do an axial cut through this, which is this panel over here, we see that this muscle here is the psoas. And as you can see, this large mass is within the belly of the psoas muscle. And it's coming off at about the L3 level. So as you can see, it's kind of leaving the neuroforamina here, starting here, and it's extending below L3 down and encompassing the entirety of the lateral margin of the spine. And this is characteristically a nerve sheath tumor. It's usually benign, and it is typically removed in a near en bloc fashion if possible. And so this gentleman had multiple opinions, and most of the surgeons wanted to approach this posteriorly, remove all the bone around the left side of the spine and the vertebrae, and try to access it this way. However, when I saw this gentleman, I saw that the lesion started at the level of the neuroforamina and extended outward. It did not extend into the spine. So my thoughts were, if I were to have to remove all this bone, this would highly destabilize his spine, and ultimately he would need a fusion surgery with screws and rods. And so my approach was going to be different. I decided to approach the spine through a lateral approach. And because of my expertise in lateral spine surgery, I felt that utilizing the technology from NuVasive and Globus, I could use the retractor and I could access the tumor from the side. I could work around it, and my hope was I'd be able to remove it in one piece. I accessed this from the side. I was able to feel with my finger this lesion, and I was able to put the dilators for the retractor right down on the top of the tumor. I put the retractor in, and I was actually able to sweep this small amount of psoas muscle here away from the tumor. I was able to then circumferentially work above, below, and behind the tumor. And the important part is there's two nerve roots that leave L3. There's a motor and there's a sensory rootlet. And at this level, typically these tumors are attached to the sensory rootlet. They're typically not attached to the motor rootlet. And so I was able to trace this tumor around. I identified in the foramen where it started, which was right here. My initial hope was that this was a sensory root, because if it was a motor root, there was a high likelihood that he'd have a weakness in his quadricep muscle. As I traced it down, I stimulated the nerves, and I did identify that this was attached to the sensory component, and I found the motor component was lying just deep to the tumor. So I traced the motor root, I had the sensory root isolated where the tumor was, and I was able to remove this tumor in one piece through a minimally invasive approach, which is a lateral approach to the spine that I do every week. I have a post-operative film just to show kind of the trajectory. As we can see here, this was the trajectory to the spine. The tumor is completely gone. There's no residual tumor whatsoever here. We've identified even down into the area where the tumor bed was. There's no residual enhancement here. I'm going to show you this is the immediate post-op, so you can kind of see the trajectory that I took. So here we have pretty good evidence of the trajectory, and so as you can see, there's a little bit of fluid in this area and just some swelling from the trajectory we took. This here is the motor rootlet right here of the nerve, and as you can see, we came right down on this lesion. This is where the whole tumor sat, so it is completely removed. As you can see, we came right down into the foramen through this trajectory this way. We identified all the nerves. This is the exiting motor nerve. You trace it down, you have excellent motor nerve preservation distally. Tumor is completely gone, there's no residual. You can even see the motor nerve here embedded in the psoas muscle. He remained neurologically intact, and importantly, he did not have any sensory deficit in the left quad, because this nerve root was actually pretty much non-functional from the tumor. He's 4 years post-op, and he has no recurrence at all. The pathology did come back as a nerve sheath tumor that was consistent with a schwannoma, very low-grade benign lesion. So just a very interesting look at how to approach the spine from different angles and access pathology with doing as little disruption to the surrounding tissue.